Welcome, everyone. I want to thank everybody for joining us this evening. Tonight, we are hosting Karen Ashforth. I'm personally excited to have her as a speaker tonight. She's going to talk about the relationship between fibrosis and lymphedema here to the Lymphie Strong community. My name is Veronica Cineres, and I'm the founder and creator of Lymphie Strong. Lymphie Strong is a patient advocacy and support community. Every month or so, we strive to host speakers on various topics in relation to self-management and living life with lymphedema. And fibrosis is such an important topic to cover, especially for those individuals who may have gone possibly decades without getting a diagnosis like my father did. My personal story, or the reason why Lymphie Strong was founded, is because I'm a third generation primary patient. My family has had lymphedema for over 100 years. So I have 6 family members that are impacted, all in various forms. So that's kind of what drives the various speakers that I asked to speak. And Karen, I'm a huge fan of. I personally saw her way back in December of 2019. I saw her speak live on fibrosis, and it was absolutely amazing. I was blown away. I've been to a lot of conferences across the country, and I've seen a lot of speakers, and Karen immediately captivated my attention. So I'm anxious to present her to you guys, and without further ado, Karen, please take over.
Oh, thank you so much. And I'm so happy that you invited me to speak today. Fibrosis is really a big passion for me. As a lymphedema therapist, having been one for almost 20 years, I have really found that if I am not looking at fibrosis, then I'm not getting a complete treatment for lymphedema. I feel like it's so critical, and you'll find out why in my talk. So a little bit more about me. I've been an occupational therapist for over 40 years, and I have both a clinical practice as well as a consulting and teaching practice. And I've already had a few questions ahead of time, and I'm so excited that people have lots of questions. And so I'm going to be looking forward to answering those. And so just to let you know that in this capacity, I'm a teacher and a consultant. So I will not be giving specific medical advice, but talking more in generalities. And I would say that if anything that I say sparks something in you, get with your lymphedema therapist and talk to them about that, because they're the ones who can individually look at your particular situation. So with that, I'm going to go ahead and share my screen. And I need to, you need to make me a host so I can do that.
Sure. There we go.
Okay. There we go. Great. Okay. So I've got a wonderful PowerPoint that I have made just for this group. Very, very excited to present this to you. So we're going to start at the beginning, and here we go. All right. So what you need to know about fibrosis. So here are the things we're going to be covering. What is fibrosis and what causes it? And what are the different types of fibrosis that you can commonly find in lymphedema? Fibrosis prevention is so critical, but if you have fibrosis, I'd like to give you some tips on how to manage it. So starting out, fibrosis basically is where healthy tissues get hard and thickened. And there's lots of ways that can happen. Surgery, radiation, even lymphedema itself can cause fibrosis. And I'll talk more in detail about some of the specific types, but what fibrosis does is it creates this extra tissue that can block circulation, it can create pain, it can restrict movement and function, and ultimately it can snowball and make swelling worse. So if you can get on top of fibrosis, then you will be able to have a better control over swelling. So fibrosis is an inflammatory process where healthy tissue gets damaged, and it's either replaced by collagen, which is like hard scar tissue, or fat, which is lymphostatic fibrosis, which I'll be explaining in a minute. So it's a vicious cycle. If you have problems with lymphatic congestion and you're not draining properly, that can create inflammation, which then creates fibrosis, which can create more impairment to drainage. Now, the dirty little secret about swelling is that it can create a fatty fibrosis. So adipose tissue is fat tissue that gets deposited in the course of inflammation that happens as a part of swelling. So you can see on the left, in Lee's study, you've got these poor little mice. They created swelling in their tails. And on the left, you can see that there's a lot more swelling, that it's a thicker tail. But in the right, you're actually getting deposits of fat. So what happens is that the protein molecules in the swelling and in the inflammation that occurs as a result of chronic swelling attracts these fat molecules. And you start to get almost like a coating in the pipe, as you can see on the right-hand side. So fibrosis is so important that Foldy, which is basically the grand expert in terms of lymphedema, they have the clinic in Germany where they specialize in treating nothing but lymphedema and lymphatic conditions. So they have created a staging system for lymphedema, which starts with 0, which is the latent stage where you don't have any visible swelling. You might not even be able to feel it, but look, you're starting to get fibrosclerotic tissue changes. What that means is the tissues are starting to harden just a little. And then by stage 1, you're getting more. And stage 1 is a good place to stay at and not go any further, because with stage 1, you can elevate your body and the swelling can drain out. But by stage 2, that doesn't happen so much anymore because you've got a lot of fibrosis that's building up. And so the extra volume of the arm or the leg or the trunk or wherever you're having swelling, that extra volume is now permanent extra tissue and swelling together. So when you do reduce it, it's not going to reduce completely because of that extra tissue. And by stage 3, the wheels have come off the wagon and it's out of control. So I'm going to just show you in pictures what it looks like. And I want to thank all of my brave patients who let me take pictures of them. They all sign releases. They know that they're going to be used for education. But we're starting on the left with stage 0, where you can't see any swelling. But stage 1, yep, you sure can. But if this gentleman puts his legs up, it's all going to run out. Stage 2, you can see on the left side that this woman who had gynecological surgery has significant fibrosis, mainly on her left leg. She's got swelling too, but she's also got that buildup of fatty tissue. And then stage 3 on the right, this gentleman has massive lobules. And he was really discouraged because we worked to reduce him. And he was hoping that his legs would be nice and thin. And he was really sad to learn that because of the length of time that he had lymphedema and all of the fibrotic damage, that he was never going to fully reduce. So that is difficult news. Here we are with the arms. So again, you see that people have various stages of combinations of swelling and fibrosis. And as we get to stage 2 and stage 3, you can see that there's a fatty tissue buildup. And the only way to really effectively remove it at this point is through surgical liposuction. There are some treatments that I'm looking at that are supposedly melting fat, but the patients of mine who've tried it, it comes back. So I can't endorse anything other than medical liposuction by a qualified lymphedema surgeon at this point. This is lipedema. So again, you can see as you progress through the stages, lipedema has its own variety of diseased fat, and that's the hallmark of lipedema. I'm not going to talk too much about it. This is Lipedema Awareness Month, so I wanted to include this slide. And I am going to be doing a talk later on in the month for the Lipedema Project, specifically on lipedema and fibrosis. So if you want more information specifically about lipedema, I would love to refer you to that talk. So really, prevention is best. Lymphostatic fibrosis, which is what I'm talking about in terms of the fatty buildup, is the most common form. And it's created from lymphostasis. The key is performing regular decongestion. Even if you already have fibrosis, it prevents the formation of further and greater amounts of lymphostatic fibrosis. So preventing is the best. So we're going to talk about different types of lower body fibrosis. And I've included 2 pictures for you. The one on the left is somebody who has chronic venous insufficiency, which is the most common form of lymphedema in the Western world. And this particular person has, I love this picture. It's a great teaching picture because she has a combination of several types of fibrosis. So you can see the inverted champagne bottle leg. So that's the lipodermatosclerosis, which means that she's got kind of a buildup of scar tissue around the ankles that keep her ankles relatively thin, but then her calves balloon up. She also has dermal fibrosis, which is where the circulation to the skin is impaired. And so you start getting growths on the skin that can be mossy or warty or even bigger. And then she also, on her left leg, you can kind of see, kind of in the middle of the leg, there's a little white area that is surrounded by, purple on either side. And she has had cellulitis numerous times. And what happens with a cellulitis infection is if a leg is not decongested, or an arm or any part of the body, if it's not decongested right away, that infectious waste can actually form a gluey plaque of excess waddy tissue that can be almost like someone shooting a staple gun, and it just laminates all the tissues together. It becomes very hard, and it's not a pleasant thing. And what it does is it creates a vicious cycle, because you can get extra infections because the circulation is so impaired. Speaking of impaired circulation, the foot on the right is a gentleman with primary lymphedema, and you can see that he has definitely swelling, but he's also got a lot of fibrosis. I mean, look at his poor toes and just the lobules that are happening on his ankles, for goodness sake. So we definitely don't want it to get to this point. Even if it gets there, there are still things we can do, and I'll be talking about that in the clinic. So next, we're going to talk about upper body fibrosis. I know I've skipped over a few areas, and I'm going to pick them up in the next one. So again, lymphostatic fibrosis is the #1 fibrosis that we see because all lymphedema patients have it, but many of them have surgical scars. So you can see on the upper right, this lady has a surgical scar that's kind of keloidy, and it's been radiated. You can see the discoloration that's happened as the result of radiation therapy. On the left, you can see a cord, actually several cords that are coming out of the armpit. And these can really restrict motion and create quite a bit of pain. So that's a type of fibrosis. On the bottom is fat necrosis. And this happens sometimes when we see grafting. There can be all different sort of precipitating factors for it, but it can form little BB-like jaggedy, hard areas in the tissue that if we treat them right away, we can sometimes soften them and get them to reabsorb. And if they go too long, it's probably best just to have a surgeon remove them because they can be quite uncomfortable if you're laying on them. In addition to the ones I just talked about, you can also get a seroma fibrosis. And seromas are pockets of fluid that can occur anywhere in the body. They usually occur after surgery or trauma. And if this area is not decongested, it can start to harden. Wound bed fibrosis is where you get hard tissue forming around a non-healing chronic wound. And then I also talked about postcellulitis fibrosis in the last slide. This is an example of lipedema fibrosis. And on the left, you can see the subcutaneous adipose tissue, which is diseased fat, diseased connective tissue. And on the right, you can see the little nodules that can occur. And this is in stage 1 lipedema on the right, and they can get very large. They can start out, fairly small sized, where they're barely able to be felt, and they can get, significantly larger to where I've had some patients have a lot of pain laying on one side because they're protruding and poking through the skin. So the tests that we do to look at fibrosis and lymphedema are pitting, Stemmer's sign, tissue extensibility, and ultrasound elastography is something that's becoming on the forefront. It's something that I've played with a little bit. I don't know a lot about it yet, but I think it has a lot of promise. So these are tests that you can even do with yourself. So the pitting test is basically where you're depressing the tissue and holding it, and then seeing if you have an indent that's left there. Heavily fibrotic tissue will not pit. But if you have a combination of fibrosis and swelling, then it may pit. Stemmer's sign, you can see in the middle that this patient has a lot of swelling in his hand. And so with Stemmer's sign, you are basically pinching the top of the second toe or finger. And if you can't get a fold of skin, kind of like on the right-hand side, you can see there's a little bit of a fold there. If you can't get it, then that would be a positive Stemmer's sign. And then tissue extensibility is just another way of looking at how much can the skin move around? How thick is it? How dense is it? How hard is it? And then this is an example. This is one of the clinical tests that I did with one of my patients that looks at ultrasound elastography. So you can see the little red areas are areas that are denser, and the blue areas are not as dense. So that gives us some clues in terms of, what's happening with the fibrosis in different parts of the body. So our goals are to decrease the symptoms of both lymphedema and fibrosis. We want to lower pain, we want to lower immobility and dysfunction, and we want to compensate for damage to the lymphatic system. We want to help the tissue remodeling and healing, and to reduce the fibrosis formation and the maturation. And that is going to help prevent lymphedema from becoming worse. So these are some areas that I look at in treatment in my clinic with my patients. And we're going to go over these, not all of them, because some of them are things you can do. Some of them are things that a qualified therapist would do. Manual therapy is very, very important. And I think that's something that everyone should be doing with themselves. And traction assisted just means that you're using either a rubber glove, or I like using those donning gloves because they've got some, stick to them. You can also use rubber gloves, but I don't think they're as friendly to the skin. And so basically, it's helping to give a little bit of traction, which means that you're pushing or pulling the tissue either sideways or down or both. And it's helping to kind of mobilize it a little bit so that it's not as stuck. Antifibrotic CDT. So CDT is basically looking at complete decongestive treatment. And the component of that we're going to be talking about is manual lymphatic drainage, which is usually very light. But when someone has fibrosis, the experts are in agreement that you have to use more pressure. Because if you're just going light, you're only going to be affecting just the very surface. And fibrosis can go all the way down through the tissues. Myofascial release is a specific therapy technique that looks at creating movement in tissues. And that's all I'm going to say at this point. A lot of lymphedema therapists like to throw that into the mix. And likewise with quadrivis, that's a very specialized technique that I had the privilege to study that works well with lipedema. AAPROM is basically movement with and without this traction release. So sometimes what we find is that if you are moving parts of your body at the same time that you're massaging them, that can create extra release. And likewise with neural tension. Sometimes fibrosis can actually impinge nerves, and people can get numbness or tingling or pain. And so using specific techniques that help to release the nerves can give relief. There's a lot of modalities out there. So positive pressure modalities are things where a therapist might be using an instrument to rub on scar tissue, not in a painful way, but in a way to help to get it to budge and move a little bit. There's a lot of different types of negative pressure. I use cupping in my clinic. I also use different machines that create suction like cupping that help to lift the tissues. And I've seen remarkable permanent results with these. Light therapy is wonderful. I could not practice without my laser. And I find that it's probably the most powerful tool in my clinic because it really helps with inflammation. It helps to remodel and soften scar tissue. It helps with pain. It does it all. Thermal modalities are things we have to be very careful with lymphedema because heat can sometimes increase swelling. But sometimes the trade-off is worth it if you're dealing with a stuck cord. So also, Kathleen, listen, if you're in the audience, hi, and you're the one that turned me on to cooling, which can be very anti-inflammatory and can help fibrosis in that way. Ultrasound is another clinical modality, as is microcurrent. Vibration, I love. So whether it's using a handheld vibrator or a vibration plate, some people use HEVA mats. There's all sorts of different ways to vibrate tissue, but that's a way of getting things moving and unstuck. Dry needling, I do not personally do, but I do use acupressure points, and I do refer a lot of patients to acupuncturists. In some states, physical therapists do have licensure to be able to do dry needling, and I've had it done to myself, and it is phenomenal for working on scar tissue. So that's something to look into if you've got a stubborn scar. Silicone scar gel is something that I use with many of my patients, and it's very effective. It's something that you have to stick with for, I would say, a couple of months, but it does show an effect, not just superficial, but it can go deep too. The silicone scar gel can also be You can get it in a kind of a liquid form, in a pad form. I prefer the pads because they're reusable, they're easy, but both of them are evidence-based in terms of helping to soften scars. Oh, how about that? I have a slide on this. I'm not able to use my external monitor right now because Apple did an update and they don't play nice with each other. So this just gives you a little bit more information about the silicone scar pad. Okay, now we're going to talk about compression, because that's something that everyone needs as a treatment for lymphedema. And if you can choose your compression so that it also helps your fibrosis, it's win-win. So we're going to talk about the different types. I personally love textured elastic that has a micro massage, as well as quilted is great for nighttime garments. Sometimes I'll have people in boot camp where they're in quilted 24/7 for the first couple of weeks while they're reducing. I would say that most people, to be sustainable, need low profile during the daytime and wear bulky at night. And then there's different ways of increasing the effects. If you're wearing it and you exercise, or you have bulk over it, like bandaging or wrapping, the class, in other words, how much compression and how much external pressure you put. So these are just some examples of, on the left is a textured circular knit that's not medical grade. So for stages 0 and 1, this is great. Sometimes I'll layer it up with wraps or bandaging with stage 2 or 3. On the right, you can see custom flat knit. And not all flat knit has an antifibrotic weave. There are a couple kinds that do, and they can be very, very helpful in creating a micromassage to the tissues. So the main advantage of elastic compression is that it is low profile. And you can get the custom flat knits for the upper extremity in classes 1 to 3, in the lower extremity in classes 1 to, I believe, 4. And then these are just some examples I'm throwing out for the textured circular knit. You can get them on Amazon. A lot of vendors have them, and they can come in larger sizes and lots of different varieties for different body parts. I personally wear textured circular knit pantyhose when I fly, and it's the most comfortable thing in the universe. So quilted compression, you can make something or use something with noodle foam, which is basically just a channel foam that is commercially made. Orange foam, you can cut little channels in it. A little bulkier would be chip foam pads or garments. Cherry pit pads are very aggressive, but they are very effective. I actually created that a little over 10 years ago. I did a study and presented it in Australia and published it in the British Journal of Lymphedema, because we really found that using the cherry pits with scar fibrosis in particular was very, very effective. So again, increasing the antifibrotic effects, you can use bandages, you can use Velcro wraps, you can use them underneath sleeves or stockings, or pneumatic compression. So there's a lot of ways of increasing that pressure. This is just an example of a few different pads and different garments. I mean, they can make garments for any part of the body. It's amazing. And you can actually even make the cherry pits into garments. So I'm going to talk last a little bit about intermittent pneumatic compression, because for so many people, it is a godsend because it can be very, very powerful. It not only decongests swelling, which increases circulation and promotes healing, but using higher pressures, you can soften and remodel hardened tissues. So if your tissues get softer, you've got less obstruction to lymphatic circulation, which gives you increased spontaneous circulation, which means it's easier and better to manage lymphedema and fibrosis. So this is an example of a patient who has fibrosis mainly in her hand and her forearm. She had a mastectomy. She's very scarred down. She doesn't have a ton of swelling in her chest or her upper arm. So using just an arm sleeve is perfect for her because it's really easy to get on. This is an example of a patient that has breast fibrosis. You can see she had a lumpectomy. When I first started seeing her, her nipple was inverted. So it was totally inside. So she really got a lot of softening in her breast and uses pneumatic compression on a daily basis. And I recently saw her after about 4 months, and her fibrosis had continued to soften. This is an example of an axilla chamber that is used for cording and scar tissue. And so there are some products that have this, and this can be a very useful tool. This is an example of treating the bilateral upper body. So this also treats, you can see this patient has lymphostatic fibrosis in her torso. Here's my lady with the Lymphedema with the chronic venous insufficiency. And so she's using leg sleeves to help to keep her legs soft and prevent infections. And then this is an example of a pantsuit that can treat the genitals and the abdomen as well as the legs. So for people that have lymphatic damage that's more proximal, this is more appropriate. And then you can also even find systems that work with bariatric patients who are ranging from 330 to 700 or so pounds. So that's the part of my lecture that I wanted to give you ideas and hints, but I think the fun part is going to be some of the Q&A. I do have a website. You are welcome to email me, and I'm happy to answer your questions right now. So I'm going to go ahead and stop sharing, and that will give me access to some of the comments. Let's see, chat. Here we go.
I don't know
Okay, so I had a couple of questions that were sent ahead of this talk that I'd like to start with. But if you want to go ahead and drop a question into the chat, I am very, very happy to address that. So I'm going to start with a question, and I'm going to keep all this anonymous because I don't necessarily have people's consent to discuss their personal, medical condition. And also, for the purpose of this talk, we're basically just doing real quickie Q&A here. I'm not doing a full-on lymphedema evaluation. So I don't want anyone, and especially the people who ask these questions, these are not specific treatment suggestions. I'm just giving ideas and advice in a general way, but it's going to need to be tailored to each individual by a lymphedema therapist who can actually really get with the person, get a good history, go through some testing, and really do a more thorough look than I can do in the scope of this lecture. So there was a question that was asked about how someone can consult with me. And I do telehealth on a private fee-for-service basis. And if you want to see me in person, I'm kind of on the move right now. So I'm starting a new work assignment tomorrow in Santa Cruz, California at Dominican Hospital, and they take all kinds of insurance. So that would be one route. What I do with patients who travel from afar, because I've had people come from all over the United States and, East Coast and Texas and even Hawaii, is I'll usually recommend to people that they make 2 appointments back to back so that we can do a assessment the first day, and then I can go into treatment the second day. And that's going to give a lot of information. Plus you get a little vacation in Santa Cruz. If you don't make it by the end of August, well, I don't know. Right now I'm committing to the end of July, and maybe I might go into August, but after that, I'm going to be in Stockton, California, which is not nearly as scenic as Santa Cruz, but I'll be at St. Joseph's Medical Center, and they also take insurance. So those are ways that if you wanted to see someone in person and you don't have someone in your area, but I would suggest, and I'm going to just drop this in the chat, there is a great website, and it's CLT-LANA.org, and you can look up your area and find board certified lymphedema therapists. And that is a great way to find a practitioner if you're looking for someone who has specific information. So, oh, and also, I'm going to be speaking in Boston and in Denver in October at the NLN and the AVLS conferences. So if anyone is interested in an in-person consultation in either of those areas, I'll be in the neighborhood, and that would be fee for service. But you know, a lot of people are asking, where are you traveling? You're going to be in my area? So let's go on to some of the questions. I have a question here saying, I have scar tissue in my chest from having surgeries and radiation related to my bilateral breast cancer and reconstruction. The scar tissue is blocking my lymphatic fluid from flowing. I see a CLT who is using lasers and cupping to try to break up the scar tissue. I am getting some relief. Yay! Have you heard of these methods? And if so, are they a permanent fix? Okay, I'm going to answer that question first. I do use those methods, and I find that they have permanent effects. However, if you have uncontrolled swelling, if the swelling is not under control, the laser and the cupping are only going to do part of the job. So I think it's real important to get that swelling under control. And yes, I do see patients that, I'll tell you my favorite story. This is a patient who had a lumpectomy, and she was 30 years post, and it was on her right side. And her breast was so painful and so swollen, and she had this gnarly scar tissue. So we worked on it using those modalities for about a month, and her pain went away, and her breast went down 2 cup sizes. So I see results like that all the time, and I believe in these modalities, and there are lots of them. As you can see, I just kind of went through just this whole list, and depending on the individual and the particular situation, there might be times where I would recommend one thing over another thing. So again, I'm throwing out generals here. So the next question from this same person is, can scar tissue redevelop once I stop this therapy? That's an interesting question, because I don't think that the scar tissue is going to redevelop, but it can mature. What that means is that if you have surgery, the bulk of the healing of the scar is going to happen in the first 6 months, but the scar will continue to mature for up to 2 years. So for that reason, when I'm working with my patients, just like the lady that I showed you that had the nipple that used to be inverted, I asked her to come back after a few months because I wanted to do a tune-up, because I knew that not only was her surgical scar going to mature, but she had severe radiation fibrosis. And they say that radiation fibrosis matures for up to 2 years. And then depending on the dose and the part of the body and situation, it can be the gift that keeps on giving. So sometimes you just have to really stay on top of that, particularly, I think, with people that have head and neck swelling as a result of radiation therapy and you know, head and neck cancer. So yes, I believe you can help permanently, but it's kind of like playing whack-a-mole, because the scar is going to continue to mature. So you're going to need to keep at it for a while. And I would say that after a couple of years, it's going to be in a much better place if you keep at it. But if you just do a little bit of treatment and then the scar continues to mature, the radiation continues to mature, then it could create more problems down the road. So let's see. Another question from the same person is that her thighs have recently begun to swell and are jiggly, and haven't been officially diagnosed with lymphedema, but the CLT recommends compression. If I don't wear compression garments and is indeed lymphedema, can my jiggly thighs turn fibrotic? Unfortunately, yes. So I would say the easy way to do it, since they're jiggly right now, is maybe if you're at a stage 0 or 1, is start with something that is non-medical grade that will give you a little compression, and just notice what happens after you wear it for a while. Does it help to reduce your legs? And if so, then I would just go full on and investigate what other things can your therapist help you with that are going to prevent this from being a bigger problem. Because if you can catch something right from the start, right early on, you have so much more power to influence the maturation of either scarring, radiation, or to prevent the lymphostatic fatty fibrosis from building up. So definitely go for it early, absolutely. So I've got another question, and this is regarding fibrosis in the groin and the pubic area. And the question is, how do you break down the fibrosis there? And what millimeters of mercury garment would you recommend for the pubic, groin, abdomen area? It is very difficult to treat. And I just did a lecture specifically on genital edema and genital fibrosis. So that's an area that I have a lot of passion for, because I have quite a number of men and women who develop fibrosis in the genital area, and it can just be really difficult. So again, you want to work on the swelling first. Use all the tools for swelling, all the manual lymphatic drainage, and get with your lymphedema therapist to find the appropriate compression garment. And I can't give you specifics on the millimeters of mercury because I haven't actually seen your body, but I would start with something and then see what happens and build up. There are chip pads, there are cherry pit pads, things that you can put in the genital area that will help to soften the groin and create a micro massage. And it can be a difficult and problematic area, especially if there are issues of incontinence. So sometimes you have to have kind of a wardrobe of pads that you can wash so that you can, keep rotating it. And I would say that pneumatic compression using a pantsuit appliance for the groin area has really been very effective for many of my patients with genital lymphedema. If you have swelling that's in the groin area, you do not want to use pneumatic compression devices that just have leg sleeves or that have the chaps style that kind of avoid the groin and the buttocks, because that will just drive the fluid into those areas if they're susceptible. So those are some of my suggestions. Boy, I'd love to give you my talk on genital edema, because that really goes into more detail.
We would definitely welcome you back anytime. Open door.
Oh, thank you.
Well, message me.
Well, I'll tell you one little tip that one of my patients, she has genital edema from front to back. She's got perianal swelling, poor thing, and she uses a paint roller, one of those soft little foamy paint rollers. Mm-hmm. Isn't that amazing? And that really helped her a lot. So there's all kinds of creative things out there. And we're just getting the tip of the iceberg today. You're just getting a little tease and a taste. But I'm hoping that, especially if you ask questions, that I can give you, throw out ideas that you can discuss with your therapist and, maybe implement to increase your quality of life. So I see some more questions in the chat here. And so I've got one here that says, what are factors that allow fibrotic tissue to break up at all? In other words, is there stubborn fibrosis versus less so? Okay, so I think that it's very possible to soften the fibrosis and to remodel tissues so that the fibrosis is more flexible. But in terms of breaking up or getting rid of fibrosis, that's something that happens surgically. I'm still, again, researching all of these, there's non-surgical modalities. I just saw one yesterday where it's like a radio frequency ultrasound that someone was advertising for treating lipedema, but it doesn't give long-term results. And so I'm after the long-term results. And I want you to invest your time and your money and your effort into something that's going to give you permanent relief. So, I would say that making things softer and more flexible will increase circulation. It will help the lymph drain more effectively. So it is definitely worth doing that. And then secondly, I assume fatty fibrosis is not reversible no matter what one does, even if not lobules. Well, okay, so here's the thing, is that you can have fatty fibrosis with a lot of fluid in it. And so if you do a very good CDT reduction, where you are really compressing everything, then that is going to squeeze all the fluid out, as well as start to soften and remodel some of the fatty fibrosis. What I didn't tell you is that the fatty fibrosis can start out like a gel, but it can end up hard. And so it's possible to soften it and help it become more flexible. So just like scar tissue, it can be more mobile and it becomes easier for fluid to move around it and through it and so on. So I think that, there's definitely hope if someone has these hardened lobules to increase spontaneous circulation through some of these techniques I've been talking about. So next question, can a PT tell you the percentage of fibrotic versus fatty? Mine can tell me. I'm a primary bilateral patient, lymphedema patient with 60 years of lymphedema that is well taken care of, but still progressing. Well, congratulations to you for good management. That's fantastic. I would be curious. Let's see. Oh, sorry, next comment. Mine can tell me roughly where the fatty tissue is, but not really how much of my thigh is fatty versus fibrotic. Okay, so let me just clarify. There is normal body fat, and then there is lymphostatic fibrosis, which is a lymphedema fat that is created from lymphedema fluid. So again, as I mentioned, the high protein fluid is it creates this inflammatory condition that attracts fat cells. And it's kind of like making Jell-O. So when you start to make Jell-O, it starts out as this liquid that has protein in it. Forget about the fat for a minute, but it starts out as a liquid, and then over time it starts to gel. And that's similar to what's going on in the body. It starts out very fluid, but the key is that you have to just keep decongesting and compressing so that you don't get stagnant fluid, because that's what's going to create the fibrosis. So if you have fibrosis already, you need to be even more diligent, because it's going to block circulation. So anything you can do that's going to move fluid, that's going to, soften it, that's going to make the tissues more flexible, is going to assist in combating the development of fibrosis. And I'm not trying to scare you, because this is something that happens over a long period of time. So when you saw my pictures of the people with stage 3, they didn't get there overnight. It took years and years and years. And in both cases, these were people who did not follow their compression programs. And that's what got them there. So if you, just the fact that you're here, interested in learning about this and helping yourself, tells me that you probably have a program already, that you have a lymphedema therapist, that you're not new to this necessarily, and that you're looking for ways to keep yourself as healthy as possible. So congratulations for being here. This is a great group. It is a proactive group for helping people to be the best that they possibly can. So I don't want you to leave today feeling scared about just falling into stage 3, because that takes a while. And sometimes, people do get there, and it's possible to get better from that. And, you can use compression, and you can use the softening techniques to help with the circulation. But I don't want to promise people that through therapy alone that they can get to, back to square zero. That just doesn't happen. That's why God created liposuction. And I've had a number of patients undergo that and have very, very, very great results. So what really matters, though, is that you find a surgeon who is good and reputable and knows what lymphedema is and has the specialized training. You don't go to just any cosmetic surgeon because they don't know about the special characteristics of lymphedema. So I'm going to take another.
That's a great segue. We've got some other questions in the Q&A that have queued up. And one of them is, do you have a list of lymphedema surgeons? That's the first one. There.
So in terms of surgeons, I don't think there is any kind of a central list. I have surgeons that I've personally worked with. I've worked with about 5 different lymphedema surgeons, including ones in Europe. And I think that it really kind of depends on where you live and what your insurance is. I mean, there's a lot of different factors in terms of choosing a surgeon. So that is a great thing. I think that if I were to give you a list, it would be really short and really incomplete, just because I don't know everyone who's doing it. And there's got to be a list out there. So I don't know that I can answer that question today, but I can maybe help find that answer.
I just attended the Chicago Breast and World Lymphedema Surgery Conference, I think a month or so ago, that was hosted by David Chang. And I asked him the same question, and apparently there is no cohesive list, but they're working on it. So.
Good. Okay, that's good to know. And I would say that, there are a lot of really great surgeons out there who are helping to train other surgeons. So I think that we're going to see more and more of that.
Yeah, and I think what people have to realize is that with surgery, the technology for microsurgery was just developed a few years ago. I think something like 10 or 12 years ago. So the surgeons have to get the training, exactly as you said, to come up to speed with the technology.
Right. Yeah, I'm seeing lots of more questions here. So I'm going to whip through them here. I want to answer all the questions, and we still have plenty of time. So it says, must cupping always be done with laser treatment? And the answer is no. I mix and match all the different modalities depending on what the patient needs. And another question about vibration, I use whole body vibration plates. I will use them in the clinic. So I'll be doing manual lymphatic drainage while a patient is sitting on a table with their feet on the plate. And I find that that enhances circulation. Also, the handheld vibrators are useful. And I have a lot of patients who use the plates at home because they find them to be very, very helpful. Another question about light therapy is, so I'm not using infrared, I'm using near infrared. the red light and the infrared lights are in the heat spectrum. And so that's not appropriate to use with lymphedema because heat can be contraindicated for a lot of lymphedema patients. So the instrument that I use is the only instrument that's FDA approved for lymphedema treatment in the United States. And it's a near infrared instrument that comes from Australia. Any recommendations for treatment of lower extremity venous insufficiency in a person with concomitant lymphedema? Oh, lots. I mean, basically, any lymphedema treatment for when you say concomitant lymphedema, I'm presuming that's a primary lymphedema, and they often really go together and should be treated together, and pretty much the same modalities. So I wouldn't do anything different other than look for locations of swelling, because with the chronic venous insufficiency, it's mainly below the knees. But if there's swelling above the knees, then that definitely needs to be addressed. So I'm not sure if I'm answering the question. You can ask more if you want. Let's see, are there surgical procedures for lower extremity venous insufficiency? Are you familiar? Do you recommend in patients with lymphedema? So in terms of venous reflux, I would say that that's out of my scope of practice. I think I would talk with a vascular surgeon who has knowledge of lymphedema for that. If it has to do with varicosities, that could be helpful in terms of lowering pain and helping circulation. But I would find a vascular surgeon that is very familiar with lymphedema, because not all of them are. Another question, I have lymphedema in my upper arm after mastectomy. Now I have adipose tissue in my upper arm. I've been getting MLD. It is stage 2, wearing flat knit and softer compression. How do I get rid of the adipose if possible? A pump. Okay, so yeah, bad news is that you can't get rid of the adipose, but you can decongest the fluid in the adipose, and you can help to keep it soft so that your circulation is good. One thing, I don't know if this is your case or not, but sometimes I'll run into patients who have a body mass of, say, 30, 35, 40. In those cases, it's helpful for, I've found in the lymphostatic fibrosis, to reduce overall body mass, because that is the #1 risk factor for lymphedema and can help to kind of slow down the out of control runaway train of fibrosis creation. So that's something to just consider. I'm glad you're wearing flat knit. That's great. You may want to consider a pump. I don't think that it's going to eliminate the fibrosis, but it could certainly help to soften it. Okay, so advice specifically about a vibration plate. So there are a few articles out there. There's one where they used it after breast cancer and one where they used it with lipedema, but there aren't any specific protocols that I'm aware of. I think still it's a fairly investigated treatment. The clinical buzz is that it works really well, but there's not a lot of actual studies on specific frequencies. So I think that there's a lot of different types of vibration in terms of how much money you're going to spend. And most of my patients are not going to pony up $3,000 to $5,000 for a real expensive vibration plate. They're going to buy something that's maybe a couple $100s. And those work. So I can't tell you if the expensive ones work better or not. And I don't have the evidence to tell me exactly what settings work best for which type. So I think, the answers are still coming in on that. Let's see. In just over a year's time, I've been told by a CLT that I had light fibrosis that went away after massages and bandaging with foam. Then no mention of fibrosis at my first ICG and evaluation at, I'm not sure what MSKCC is. Months later, I went to another highly recommended surgeon who did a second ICG and eval and said that I do have fibrosis in the lower leg and should have lipo done as soon as possible because fibrosis can only be removed by surgery, not broken down, and this will only get worse. Is this an uncommon opinion or could it be true? Okay, so that's a lot of questions all in one paragraph. So I would say that the CLT that told you that your light fibrosis went away, I would question that because I think it can be softer and I think you can remodel it and I think you can get rid of swelling. But I have not heard of fibrosis being removed in a therapy setting. I think you can greatly improve the environment, but I'm not sure about going away. So, and let's see, I didn't see what part. So I'm presuming that this is all in the leg. And so then after the second ICG, so I guess the question I have for you back at you is, do you feel, I mean, how do you feel about your leg? Because most fibrosis is not a 911 situation. It's not a situation where it's life or death and you have to have surgery or else. I think that a lot of my patients choose liposuction because they'll have fibrosis in one leg and not the other because they're affected only on one side and they're at a fall risk, or their body is very asymmetrical and they want to correct that. So there's a lot of reasons out there for getting liposuction. I don't want you to think that that's the only answer and that everyone should get it. I really don't believe that. But I think that in some cases, it's a real, godsend. So it depends. Let's see. How do I use red light therapy? How is the client positioned? Hi, Sherry. So I don't use red light therapy with lymphedema because of the heat. I use it on scar tissue for people that don't have swelling, but I use the infrared a lot, and because it's non-thermal. And in terms of positioning, I usually like to have the scar on stretch because I like to kind of combine a little bit of traction with the laser, and then I'm constantly doing manual therapy at the same time too. So a lot of times patients are either lying on their back or lying on their sides, or I have a treatment table that can position people at a 45 to 90 degree angle. So it's really pretty much in, position of comfort that I like to do. So I'm going to go back over to the chat here. And let's see. Yeah, thank you, Kathleen. Learn centers of excellence for surgeons. You can't go wrong. That is a very, very good suggestion. Okay, how do you feel about a patient using an FDA-approved handheld laser at home as a part of therapy? Well, I actually have patients who own their own lasers. And one of my patients is a little guy who has primary lymphedema from birth. And he came to me with heavily, heavily, heavily fibrotic toes. And he didn't have a good compression program. And so we basically did a whole makeover and got him some toe caps that were connected to thigh-high leg sleeves, and made sure they were anti-fibrotic. We got him pneumatic compression. His mom found a laser, she networked, and so she's been using that. And he actually did a consult for possible surgery, and they decided that he was doing so well at softening the fibrosis and turning around the swelling that they wanted to wait a few years. and let him get a little older and then reassess, with the idea being that the percentage of fibrosis that he has right now is kind of high because he's so little. But he's 4, but he's going to be getting bigger. And at that point, if they can keep it soft and keep the circulation good and keep it remodeled, then he might not necessarily need to have surgery, or at least not right away, which would be a good thing because it's kind of traumatizing to these little guys. So yeah, fast and go bandages. I just learned about them 2 days ago. I was in a lymphedema seminar, and there was someone talking about them. I have not used them yet. I've heard of them. So that's definitely an option to check out in terms of what I find in terms of compliance is that I balance between what's the most effective and what's the easiest, because I can give patients the most effective, but if it's really, really hard to do and they can't or won't do it, then it's not going to help. So if we can strike a compromise in terms of something that is not going to be a second career for them, but will give them results, and I'll educate all the way through. I'll say, you can do this, 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 or this. This is the most effective, but this will still give you results. And if you only have this much time, go for it. So fast and go might fall in that category, I think. Let's see. Help me out. Am I missing any questions? I'm kind of going back here.
I think the one on how many years can one go without
I'm seeing
bigger.
that. Yeah. Okay, great. Thank you. Yeah. It's invaluable that you will get it, inevitable that you will get it, even with management. Well, by definition, you're going to have fibrosis even in stage 0. But I think that it's about keeping that jello soft and fluid so that it doesn't harden up and obstruct circulation. So that is a question that a lot of my patients ask. They're looking down the road at how am I going to be able to manage my lymphedema when I'm older? And that is a very legitimate question, because I followed, some of my patients I've followed for decades, and people really have a real concern about that. So I think that that's a good reason to really get on top of things and to find a system that is going to help not only prevent progression as much as possible, but I like to see my patients go into remission. Isn't that an interesting thought? I mean, I have lymphedema patients who have actually gone into remission. They still have a little bit of fibrosis. They still might have a little bit of swelling, but the bulk of swelling has gone down. And there's a lot of different ways to accomplish that. Again, I'm not the fat police, but the patients who do the best are the ones who go from 300 to 180. And I've had people put their lymphedema equipment in the closet. I say, don't give it away. Don't throw it away, because you just never know. You don't want to invoke Murphy's Law. But, that has been really effective. And I've seen it go the other way too. I've seen my patients gain 20 pounds. And statistically, it's 7. 7 is kind of the break-even point when you start to really see it getting either better or worse. So either plus or minus 7 seems to be what's going to really make a difference. And boy, I see patients just start struggling uphill as they gain weight. So I would say in terms of aging, that's probably the best thing that everyone can do in terms of you see long-lived skinny lab rats. I mean, they're the ones that don't get heart disease as bad. They don't have strokes. All of these different complications that can happen with high body mass. So that is the single one most powerful thing. And I didn't really talk a lot about eating with lymphedema and lipedema, but there are a number of people out there. Leslie Keith is one of my favorites because she's so down to earth and makes it so easy in terms of, she espouses the keto method. I just spoke for one of her conferences, and I talked about cheating on keto, which is basically how can you ease into keto and get a lot of the benefits, but still be able to have, plant-based sweeteners that aren't dangerous for you. So there's lots and lots of different ways of doing things. And so I think that's all I'm going to say on that.
I've had Leslie speak twice to the group.
Isn't she a dear?
Yeah,
she's so great. Yeah,
it's great.
Yeah. In terms of intensity, are the beds with a vibration mode similar to a vibration plate? That is a very interesting question, and I don't know the answer to that. I would think that you would get some kind of benefit from a vibrating bed just because it does help circulation. But again, we don't have the scholarly research on the optimum intensity and frequency and time and all of that. So I think I have to advise people to, if you're going to try something like that, start real easy, start real slow. I will give you a caveat for vibration plates. When we started using them in our clinic, we used them a lot with some of our neurological patients because lymphedema and neurology, we share the same gym. And my co-therapists in the neurology department were finding that having patients exercise standing on a vibration plate is like doing 10 times the work if you're just standing on solid ground. And so I even observed some patients having blood sugar incidences because you think that 10 minutes on a vibration plate, what can that do? But it was really giving these people more of a workout than they were used to. So if you have blood sugar issues, I would be very cautious about using a vibration plate for very long. I would start with 5 or 10 minutes and then just increase it gradually. We're getting a lot of vibration questions, which I love because I think vibration it's fun and it really shakes things up and it really loosens things up. And I have found it to be very effective. So it's kind of a fun thing to do at home, and you can multitask. There's all kinds of things you can do. You can do self-massage and a lot of other modalities. So I see we're getting close to time. Anything else? I think. Do we have any other questions? Okay, crickets. Well, I am so grateful that we had such great attendance today and, great questions. And I definitely would love to come back, maybe in the winter or this spring. So let's definitely stay in touch on this. And
I will definitely send you an email in the morning so I can schedule you for the winter, maybe Christmas. I know you're a hard person. You're a hard person. Not hard is the wrong word. You are a very busy person, busy helping the community. And I personally want to thank you for all your work, and both on the research side and of course on your day-to-day with all the patients that you help, and especially for taking the time to visit the Lymphie Strong community. I didn't say this in the beginning of the recording, but Karen and I have no financial relationship. I'm not paying her to speak. She's not associated with me, and she's just really donated or volunteered her time here to be with her. And so I want to thank her from the bottom of my heart for doing it. I was furiously writing notes. I had my own questions. I may even follow up individually for my own case of lymphedema. So thank you for being here. And I want to thank everyone, all the participants who joined in and gave some great questions and great feedback and comments. Thank you all for joining us this evening.
Great. Thank you.
Good night. Bye-bye.